Infant psychiatry. What is it about? Once, infants as such were not interesting to mental health clinicians nor to scientists because they were thought as unable to feel psychic pain, to perceive others' emotions, nor to remember painful or traumatic events. To psychoanalysts, infancy was interesting only as the source of potential fixations in adulthood, but infants were not interesting as such. What we know today is that experiences in the first years of life shape the brain by strengthening, weakening, or pruning synapses that have been formed from primarily genetically encoded information, by increasing linkages among neurons through repeated experiences, and by laying down myelin and thus increasing the speed of conduction. Where do all these processes take place in the brain? Early interpersonal affective experiences have a critical effect on the early organization of the limbic system, that is an area of emotion processing, organization of new learning, and capacity to adapt to a rapidly changing environment. So, the clinical significance of brain development research is that interventions targeted to improve and/or to change early childhood experiences can be seen as interventions at the level of brain and mind development. The model that is called the transactional model of development is used as a working model for diagnosis and treatment of very young children. In this model, C stands for child and E stands for environment. On each of these, a whole bunch of factors impact all along the life. So we have genetic factors, biological factors, cultural factors, life events, and psychological factors. All these impact both the child and the environment, and along the time it impacts them differently, so that our capacity to predict what will be the emotional and developmental status of the child from point 1 to point 3 is quite low. But on the other hand, it leaves space for intervention. What this model says is that there is a complex interplay between the child's factors and the close environment factors, mainly the parents, so that their interaction, their relationship is impacted by both factors in the environment and in the parent. And we will come back to that point when we talk about targeting risk factors. Why are our attachment experiences a major target of intervention? Attachment research has shown the life-enduring impact of the caregiver's reaction to the infant in times of distress. For example, a consistent, efficient, sensitive, and contingent parental protective and comforting response to the infant's distress will lead to the internalization of the parent as a secure base in the infant's mind, and secure attachment behaviors will be observed in the child. This is very different from the situation where parents reject the distressed infant's attachment needs for closeness and protection. And this rejection will lead to the internalization of the parent as an insecure and hurting figure. Insecure avoidant attachment behaviors will then characterize the child. Another type of situation is the parental unpredictable, labile, alternatively negative and positive reactions to the infant while he is or she is in distress. And this will lead to the internalization of the parent as a non-reliable and conflictual figure. Insecure, ambivalent attachment behaviors will then be observed in the child. The last type of attachment representation and behaviors is the frightening, frightened type. That is when the parent reacts as looking both frightening and frightened when he's facing the child in distress. And this will lead to a disorganized pattern of attachment. The infant is paralyzed between his need for closeness and his or her fear of the parent. This pattern is in correlation with later psychopathology. The role of attachment security in the development of the self has been shown as very important because experiencing a secure attachment with the primary caregiver is a major tenet of the development of a representation of self as a valued and competent individual. In contrast, an insecure attachment with the caregiver plays a major role in the development of representations that are characterized by mistrust, anger, anxiety, and or fear, and this is what we often find in borderline personality disorders adults. Good enough parenting has been linked to security of attachment and to the development of empathy. The development of empathy necessitates the childhood experience of good enough parenting, that is, by definition, parental sensitivity and empathy. And indeed, there is a significant positive correlation between security of attachment, the development of a theory of mind, and the degree of empathy the child develops toward peers, and stays during adulthood. So the scope of infant psychiatry is first to detect early the infants at risk for maladaptive development. Second, early intervention for those infants who have already developed symptoms of emotional distress, and the planning for following studies. The risk factors for negative developmental outcome have to be known in order to target our early prevention interventions. So risk factors, we divide them into the risk factors in the infant, in the parent, and in the environment. In the infant, biological risk factors include severe prematurity, congenital diseases, medical illnesses, and so on. Constitutional risk factors are, for example, difficult temperament, vulnerability, and especially it is to know the interpersonal risk factors for the infant's development, that are the adverse relational experiences, mostly with caregivers, and especially the disorganized types of attachment relationship that have been linked to abuse and neglect experiences, but also traumas and losses in early life may become risk factors for the infant's development. Risk factors in the parent include poor education, low IQ, physical and or mental illness, severe personality disorders, unresolved trauma, losses, and past abuse in the parent's history. Disorganized attachment of the parent himself is a very strong risk factor for disrupted parenting behaviors. And finally, we have to know how to look for risk factors in the environment that include poorness, lack of social support, and adverse life events. It's not enough to detect risk factors. We need to detect also the protective factors for each of the infant and parent who come to us, because this will become part of the intervention. Protective factors, again, are divided into those in the infant, in the parent, and the environment. In the infant, it includes, again, biological factors, mainly good health, constitutional factors such as resilience, easy temperament, above average IQ, and interpersonal good experiences, secure attachment, growth-promoting parent-infant relationships. Protective factors in the parent include maternal education, IQ, healthy personality of the parent, good family functioning, and stable marital relationships. And protective factors in the environment include the social support. Better to have a little bit of money, it's always good, as protective factors, and positive life events are also protective factors. By the way, a good psychotherapy may become a protective life event. The common reasons for referring an infant to a child psychiatrist include feeding and eating disturbances, sleep disturbances. These two are very common reasons for referral. Developmental delays that are thought of having maybe an emotional component, excessive crying, irritability, psychomotor agitation. Of course, medical reasons have to be ruled out. Behavioral problems, especially aggression, inadequate parenting, neglect and abuse, major parental psychopathology, withdrawn behavior of the child, and peers relationship disturbances are some of the most common reasons for referring an infant to us. Then we diagnose these infants. The diagnosis in the first 3 years of life is based on what is called the diagnostic classification for 0 to 3, revised version. A new version is currently under work and will be published in December 2016. It will be called the diagnostic classification for 0 to 5. What is important to know about it is that it is based on 5 independent axes. The axis 1, the primary disorder of the infant. These are for situations where the symptoms that the infant exhibits are observed beyond the context of the parent-child relationship, for example, in the daycare, outside of the home. This is different from the axis 2, parent-child relationship disorders, where the symptoms are observed only in the context of the relationship. The axis 3 includes the developmental and or medical conditions. The axis 4 includes the psychosocial stressors, and the axis 5 describes the actual level of functioning of the child at the time of the consultation. Just a few words about therapy. There are different approaches of parent-child psychotherapies for disorders in the first 3 years of life. The main point is what Dan Stern named as the parent-infant relationship is the patient. So we do not treat only the child, we do not treat only the parent, we treat what's going on between them. The different approaches of child-parent psychotherapies each of them have different characteristics, but their main goals are the same. So I will just mention the goals. I will not go into the different types. We don't have the time. We wish to identify the parent's disordered perceptions of the infant, to identify the infant's characteristics that have triggered the parental conflictual or narcissistic projections. And finally, we need to make sense of the infant's symptoms in the light of the first two. So in the light of the parent's projections, as well as in the light of the infant's characteristics that have triggered negative attributions in the parent. And the process is named the facilitation of parental reflective functioning. Basically, we use non-verbal and verbal messages that are conveyed during the very small interactional events during the session. And this is our main tool for the therapy. The baby's presence in the therapy session is very important as a trigger of unconscious affects and projections in real time in parents. It's very different to listen to parents describing their infant and to look at the infant and to look at what's going on between the parent and the infant in real time. The baby's presence also enables us to see the baby's own characteristics that have contributed to the parent's disordered representations. And also the baby listens to the therapist's comments and perception. And so he can hear the therapist explaining his or her behaviors differently from what he has been used to listen or to hear at home. It will not be, for example, "you're a bad boy," but "you're trying to tell us something through your behavior." This is what we call the therapist reflecting functioning stance. And also, the baby will have the opportunity to experience a new way of being together with mom and dad. So, to conclude, child psychiatry starts in infancy, and therefore this is a domain that you need to know. Thank you very much.